Evening, everybody. Hope you're all doing well. Hi, Lisa. From Seattle. Excellent. Should be around lunchtime in Seattle, is it? Hi, Demi. Hi, Laurie. Yeah. Yes, I would appreciate it if everybody could like the stream and make sure that you're in live chat and not top chat so that you get to see all the comments everybody's making. So, yep, great to see you here. Hello, Ellie. Oh, hello, Mr. Angel Lab. Oh, it's excellent to see quite a few people on here already. I was wondering with the short notice how many people would be able to make it. Unfortunately, I have been very quiet on YouTube and Instagram for the last few weeks. I've not been the best. So yes, I am starting to feel quite a bit better. Unfortunately, having sort of a chronic illness and then having to deal with full-time life can be quite tricky. So I didn't know whether anybody was interested in me explaining what Ehlers Danlos Syndrome is later on, but I can. And then I've also had some lovely viral infection that's been going around. I did test myself a few times, but it's not COVID, it's some other virus. But I think we just have to count COVID as just one of the normal winter viruses now, just to add into that, and flu and such like. So I probably should start and run my disclaimer just so to make sure that I'm covered. So just remember that anything that I talk about in this is just for educational and entertainment purposes only. I'm not providing any individual advice. So although you can ask your questions, it will be in general and not for you as an individual. You should always go to your own healthcare professional. And also the fact that I am UK based, so I understand sort of what the licensing is and the law is in the UK and not the rest of the world. And there's can be quite a few differences. So that's my usual. Yeah, okay, well, I'll start off with that and then I'll move on to the Ozempic. Yes, it is what's classed as double jointed. So there is a whole host of conditions that are related to being hypermobile, and they're the hypermobile syndrome disorders. So people can be hypermobile for quite a few different reasons. One is through sort of training. So obviously your top gymnasts and ballet and people, they actually train themselves to be hypermobile by sort of stretching out their muscles and ligaments and through training. Some people may have it because of an underlying disorder that sort of has a low tone of their body, and some sort of things like cerebral palsy and things like this, where they have less tone of their muscles, can cause hypermobile. But then there's, sorry for the cat, then there's a whole group of conditions which are hereditary and connective tissue disorders, and that's where the collagen that makes up the body, in the ligaments, the muscles, the skin, where the triple helix should be quite sturdy, it's much more fragile. It doesn't have all the corresponding double bonds between the triple helix, and it stretches and is more fragile. So it makes the ligaments and tendons much more. I'll just show you the cat while he's interrupting. This is Nobby. Hello, you're getting all the love. Yes. So there's a whole section of genetic disorders that affect the connective tissue disorders. One of the main ones is Marfan's syndrome, which affects the collagen quite dramatically across the whole body. And people who've got Marfan's syndrome are known to have a body shape that's called the Marfanoid habituus, which makes them really tall, with really long arms and really long legs, really long fingers and toes. And quite often they could either have a concave ribs that are very sort of pronounced ribs, and they really struggle to gain weight, so they quite often stay skinny well into sort of middle age. But the problem with Marfanoid habituus is it also affects quite a lot of the organs very dramatically. So it can affect the aorta, which is the main artery coming out of the heart, and the collagen that supports that, the wall, can struggle and expand and cause what's called an aortic aneurysm, and cause sudden death, because basically if your largest blood vessel explodes, you've really not got much chance. It also can cause problems with eyesight. And I do actually have a relative that was diagnosed with that as a child, a cousin, and potentially another cousin. And then myself and quite a few other people within the family had the hypermobile part, but didn't seem to fit the Marfanoid habituus diagnosis. And I ended up going and seeing a specialist up in Leeds and discussing another type, which is Ehlers Danlos Syndrome. And there's 13 different types to Ehlers Danlos Syndrome, depending on how much other organs in the body are affected, whether it affects the vascular system, whether it affects the skin. And some of them they found the genetic markers too, except for the most common one, the hypermobility syndrome, the Ehlers Danlos hypermobility, which was also known as the type 3 originally. They haven't found the genetic marker for it. It does seem to be the most common, and that seems to be the one that I have. And yeah, it affects all the joints. So all the joints, the tendons and ligaments holding the joints together don't. So I don't know how best to show this on the camera. So a lot of my joints I can throw the wrong way. There's the diagnostic criteria to be able to, trying to do this best to the camera, where you can put your, it's your thumb to your, I'm trying to do this to the camera, it doesn't work very well. But then my elbows go backwards, my knees go backwards. I can stand and put my hands to the floor by just with my legs straight. In fact, my granny, even at the age of 80, before she had her stroke, she would still tie her shoelaces by just leaning over with her legs straight and her hands tying her shoelaces. So she kept the hypermobility all the way through into her 80s. So so damn it. Usually if you ever did silly tricks as a child to show off being bendy, if you feel as though any of your joints ever sort of give way, pop out of joint, anything like that, so it's then worth looking at. Usually a physio is best to have a look, and they can see whether it's something localized to a specific joint, that you've actually damaged the joint previously and that's why they're now loose, or whether you have it generalized across all your joints, and whether it might be because of your actual connective tissue, and that's the reason. So obviously it's looking at you as an individual and how generalized it is. Unfortunately, because Ehlers Danlos syndrome doesn't just affect the joint, the ligaments, it affects all the collagen in the body. One of the lucky things is it does give lovely, velvety, soft, wrinkle-free skin. So even though I am into the later 40s, I still look fairly young. Even my mum in her 60s still looks pretty young. So that is quite a bonus of it, although it also has the side effect of the fact that it also makes me look pretty healthy. And so people not realizing about invisible illnesses look at me and go, oh, but you look so healthy, you look so young to be having a disability. And when you try and explain it's a genetic condition, I've had it since birth, you can't be too young to have a genetic condition. But it also affects other areas such as the bowels, so irritable bowel, and because of the stretchy collagen of the intestine walls can stretch, causing constipation and slow gut motility, which is one of the reasons why I ended up becoming such a specialist in constipation and writing laxative guidelines as part of Yes, Patricia, I am talking all about collagen. I've just been explaining all about what Ehlers Danlos Syndrome is and how it affects all the collagen in the body. I've done about how it affects all the joints. I've done about Marfan syndrome, and now I'm just explaining about how my EDS affects my bowels, which is a lovely subject. But yes, that is the reason why I ended up writing laxative guidelines, because I did the research myself about laxatives. I'll answer this in a little bit, Natasha. So, your mum looks young for her age. Always been really flexible. Hyperextend elbows and knees. Yes, I would. There's the Hypermobility Syndromes Association, has a really good website with a lot of information on, as does the Ehlers Danlos Syndrome Association as well. They've got really good information on their websites as well as all the diagnosis criteria. The other, nice reminder to live chat. Yeah, the joys of an invisible illness. Yeah. It's like, again, I cannot stand up on the bus. A lot of the time when I first started using my walking stick was there for balance and a comfort blanket as such, but also just as a visible sign to say, look, I'm not perfect. I'm not a young person who can just stand up on the bus. So, yeah, and the other system and the other condition that comes along with EDS a lot is POTS, which is postural orthostatic tachycardia syndrome, and that's due to sort of the collagen in the blood vessels, plus it affects our autonomic nervous system. So normally when somebody stands up, you need to have more blood going up to your head. So you need to close off the blood vessels going to the bottom half of your body to allow you to pump it up to your brain. That doesn't work quick enough when you've got POTS. So your blood pressure drops. To try and compensate that, your heart rate tries to increase to try and push out more blood. So your heart rate increases, but you still end up not getting the blood to your brain, and you still end up fainting. So one of the main diagnostic criteria of that is your heart rate can go from being your heart rate can jump by at least 20 beats a minute by standing up, or just going straight above 120 at standing up. There are things to help with POTS, which I can always cover at a later date, but I'm just going to go back. So Patricia, you said, so it's good for you, the collagen. Unfortunately, when taking collagen, when you actually have a collagen disorder, doesn't actually help the disorder, because the reason we have problems with collagen is because our body builds the collagen incorrectly. So, and when you actually ingest collagen, you've got to break it back down to its amino acids and its peptides, and then your body's got to build it back up again, and it will build it back up incorrectly again. So yeah, it doesn't always work. Whereas collagen in healthy people who just happen to not have sufficient in their diet, by increasing that can increase sort of any mending of skin and joints in sort of healthy individuals, can promote that. And people who've got something actually wrong with the collagen production struggle. Right, so alpha lipoic acid. Pretty sure that's one of the omega fatty acids, and it is used for quite a lot of different things around the body in promoting health, but it wouldn't actually help with a pinched nerve in your neck. A pinched nerve in your neck is actually a physical problem. There's actually something mechanical going on there, and really although you could have stuff like the neuropathic painkillers that try and sort of dampen down nerve signals, the only really way of helping with the pinched nerve neck is to see a physio to actually realign sort of the neck, release the pressure on the nerve. Obviously, if that's not suitable, it would then be looking at it sort of more sort of under MRI, whether they could actually do anything else. So although yes, alpha lipoic acid it's a good acid, I've just nearly finished writing writing an episode on all the omega fatty acids, and yes, they do promote benefit in a healthy lifestyle, but actually as a supplement, they're not magic. They just help replace what you should have in your diet, if that makes sense. I'm going to try and see if I can work out. So the original thing that I mentioned I was going to talk about was the Daily Mail that decided to do a lovely scaremongering, as they like to. I'm going to try and see if I can get StreamYard to play nicely. So, if I can. Let's have a look. Hopefully, so the Daily Fail. Yes, we've called the Daily Mail several annoying things over the past. Quite often, you could actually pretty much do and say whatever the Daily Mail says, the opposite is actually probably true. You really do need to take it into consideration. So they talked about sort of the fact that the Ozempic and Wegovy for weight loss, that are then linked to some of the serious health conditions. What they forgot to say was, we already knew that. We already knew that taking these medications have side effects. Because anytime you actually have any effect on the body, you'll have whatever positive effect that you're trying for, but you're always going to have a risk of side effects. And we already knew that there was going to be side effects on the gastrointestinal tract, because that's how it affects. It affects the GLP-1 pathway, which is the pathway which is the signals from your stomach up to your brain. To say that you've got food in the stomach, to say that you're full, to say that you need to do some digesting. to say that you need to start all the pathways in regards to sort of insulin and digestion going along. That's all part of the pathway. So it does affect the GI tract. And we know from the start that it does slow down gastric emptying. It does slow down sort of the absorption of all your food, and it affects sort of the pathways with how you deal with sugars and fats. So it can potentially cause problems with that, and again with the pancreas, because it stimulates with the pancreas actually working. So we've known all along that there were side effects, and they were documented originally. So phrases like this, adding to the ever-growing list of undesirable side effects, that happens for every single medication as they come out on the market. So they will have tested the medication in the first, well, you have the first phase of trials where they check it in animals, that it seems to sort of have the effect in animals, or even in a petri dish on the cells and the receptors that they're wanting, to see whether it works. But then the first lot of tests that they do actually in humans, they test it in healthy volunteers just to get a rough idea of calculating the dosage that will be needed to actually have an effect and having some side effects. And they'll document all the effects that have happened. And they'll just take a group of, these are the sort of things that you usually see, healthy volunteers from university students, and such like, get paid some money to just go sit in the lab and get injected or to take something, and then they have to sit and record everything that happens to them. So there's always going to be things like headache, stomach ache, diarrhea or constipation listed as side effects, because at some point somebody will have that sort of side effect happening during a day, because they've just got to mention everything that they feel during that day. And then they'll have to do some statistical analysis to say the group of people that actually had an active drug to the group of people that didn't have the active drug, is there a significant difference? Is it likely to be a significant side effect? Then they will do testing in the actual sort of patient group that they're looking at. But again, they usually always look at the healthier end of those patients, rather than the more ill and fragile people that are willing to be in the test. And again, they've got to list every single side effects that happens, and up until market. So up until market, they'll have listed everything that anybody who's ever had the drug tested on them has ever felt, whether or not it's equal to placebo or more than placebo. And they will put them all down with either sort of common, and usually when they're saying things like common, they actually just mean greater than 10% of people have it. So even if only 1 in 10 people have that side effect, that makes it classed as common. And then you have uncommon, very uncommon, rare, extremely rare. And these are usually down to the sort of things that might happen to 1 in 1,000 people, 1 in 10,000 people, 1 in a million people. Unfortunately, they don't test millions of people in the trials. So when we get down to finding undesirable side effects that happen to 1 in a million people, they're not going to find that until it's been actually used in more than a million people. That's only when it's going to start showing up. And that's why a lot of drugs, when they're first on the market, have an upside down black triangle next to them, which means that any health professional that has contact with the patients, and even patients themselves in the UK, can report any adverse effect that they have while they're taking it, whether they think it's related to it or not. So if somebody has an allergic reaction and they're on a black triangle drug, they should report it automatically, whether they think it was that drug or not, whether they think, whether they might have been started on 3 drugs that week, and people need to report it anyway, just in case. And as more and more reports come in, the safety organisations will look at them. So the FDA in America, the MHRA in the UK, the Europeans, the Australians, and I think this one was looking, I think it was Canada, and then also Australia sort of looking into it. But yes. So the higher risk is this scary number. Taking X doubles your risk of Y, yeah, without mentioning the tiny risk, is still double. That is exactly the point that I was just about to make. So where they say here, 3.67 higher risk of gastroparesis, they've not told you how low that risk is. And I think when we get to it, it's in the sort of something of the tens of thousands. I've got the trial up for us to have a quick look at in a bit. But yeah, it's like saying, if you buy 5 lottery tickets, you've 5 times the chance of winning the lottery, and you're still like, yeah, that's not going to happen. You know it's not. You still know it's 5 in a million chance instead of 1 in a million chance. So yeah, it is. Yeah, they are purely to try and shock people. And you've got to realize that, yes, so 1 in 10,000 people might have a serious side effect, but you've got to balance that. Is that risk worth it to having a potential benefit in thousands of people? And also the fact that you may be preventing other conditions, worse conditions, with the use and treatment of medicines. And that's always the risk versus benefit conversation you need to have. And that should always be something that you do with your healthcare professional, is go through and actually have a discussion about sort of what are the potential benefits, how what's the chance of me having a good benefit? Is it going to improve my symptoms by just 10%? Is that going to be worth it? Is that going to take it down from being unbearable on a daily basis to bearable on a daily basis? Is it going to lower my long-term risk of other serious problems? So a lot of the times when you're talking about reduction in cardiac risk, is it worth reducing your 10-year risk of a heart attack from 50% down to 10%? Is that worth it for you or not? Or are you like, well, I don't really care what happens in 10 years' time. I'm just concentrating on the here and now, which is sometimes what we do when we're thinking about sort of the 10-year risk of treating heart disease. When you're actually thinking about somebody that's in the 90s, that's a discussion you've got to say with them. What is your quality of life at the moment? Are you wanting us to be trying to extend your life by another 10 years or not? And it's a hard discussion to have, but it's something that should be done with people. So, yeah, so these headlines are here to think so. Weight loss, have a higher chance of pancreatitis. Pretty much every medication that affects diabetes has a higher risk of pancreatitis. And potentially that can be because there has already been some sort of issue with the pancreas in the first place. The bowel obstructions and stomach paralysis. Because you're slowing down the intestine movement. And if you are already prone to having a bowel obstruction, it might just tip you over to the edge to the point. So while it's rare, so they already admit that it's rare, it's in sorts of things, it could be a risk due to the rise of the popularity. And that is something that we've got to take. And I'm not monetized, so I just need to make sure that COVID doesn't take me down. But that is the risk of side effects when you do some sort of mass program, giving out a certain intervention to millions of people in a very, very short space of time. You will suddenly have the fact that even if it's a 1 in a million chance side effect, if you've suddenly treated 100 million people, that's 100 people that are going to have that very rare side effect. So having more people take an intervention does mean that, yes, that intervention will happen more likely. So I did go down and thought, so they explain a bit about sort of how it does affect the pancreas, suppresses hunger by mimicking the hormones, and obviously it's altering how the pancreas, and so it's called pancreatitis. If I say it wrong, I am sure that Julie Joe will have a laugh at me. So, But yes, it can affect the pancreas. So I thought, well, let's go down and I'll actually find the thing. So rather than them here just quoting 4.2 times more likely, 3.67, I thought I'd actually go to the actual let's see if I can. Why does this always happen when I right, here we go. It's the adverts. That's the thing. It's the adverts that try. I don't need this section. I bet it won't let me get rid of it now. Silly adverts. So the article was a very good article, actually. They said that they've realised that the GLP-1 agonists are being used for treatment of diabetes, and they're also being used for off-label. That we already know that it's got side effects, adverse effects, pancreatitis, bowel obstructions, gastroparesis, biliary disease. And they did wonder whether the reason why this happens is because people with diabetes already have a higher baseline risk for these adverse effects. So the question was, if you're using the GLP-1s purely for weight loss and you don't have diabetes and don't already have that higher risk, baseline risk of these GI side effects, are you still going to have the GI adverse events? So that was a very sensible thing to look at. They took a random sample of 16 million patients, which is always great to try and get as big a amount possible. And they looked at the two different agents that have been used for weight loss, the semaglutide and the liraglutide. And rather than comparing against placebo, they wanted to actually compare against people that were actively trying to lose weight with a medication. So they used an active comparator of people that had been taking the bupropion and naltrexone as a weight loss agent, which acts by a totally different pathway. It's actually acting on the central nervous system and the pathway of reward and sort of addiction. So it's a totally different pathway. It does come with its whole host of potential side effects, but they're usually sort of central nervous system, cognitive brain related side effects. So it's a totally different one. So we're looking at them, and for the GI side effects will be quite different. Right. So they go all about how they do. Obviously, they looked at 16 million, but when they actually came down to it, the numbers are very small in this study. Fairly decent numbers, but you do have to take that into account when you come to sort of making any determinations of information. So they were doing it by, so they did all the calculations based on 1,000 person years. So that's for 1,000 people taking the intervention for a full year, how many of them are likely to have had that side effect? And when you come to look at the numbers, you can see that all of the side effects, even in the group which doesn't affect the GI tract, the figures are still less than sort of it per 100, sort of 4 per 100, so 4 per 1,000, so less than 1 in 100 patients. So they're still very, very low. And also with many of them, even with the confidence intervals, are very, very great, meaning the fact that they don't know. They've done it and they've done a statistical guess, but the guess means that it may or may not have caused, but there's a good indication that they might. And then you go through the discussion, and they sort of explain that there was some associated risk, but it's very, very low. So increased risk of the pancreatitis, gastroparesis, bowel obstruction, but not the biliary disease. So I did think that it was quite a good trial. And it showed that the slight risk that they found in the original trials is also there when you're just using it to treat diabetes, when just using it to treat obesity. So it's probably more to do with the mode of action than the drug, rather than any underlying disease of diabetes that was causing it. But yeah, when I actually look at the figures, I'm like, the figures are still very low, and it is something that has always been mentioned and should be mentioned. Now, that is the bigger problem when you come to how this drug is being promoted currently. So people that are having it started by their diabetes nurses and such like as part of their care, they probably will be having the discussion about the fact that we're starting you on a new medication. You should always be aware that a new medication has side effects. These GLP-1 side effects are actually a lot less than the alternatives that we would be putting you on. So quite often the alternative to the GLP-1s, which we would have used previously before they existed, was the sulfonylureas, or your glycosides, which can actually cause severe problems with having hypos, so your blood sugar going too low. They can also cause weight gain, which actually worsens your underlying diabetes. The same with having to start on insulin to control your diabetes. It itself causes weight gain, which then worsens the underlying diabetes and then leads you into a vicious cycle of then having to need to increase the insulin. So the GLP-1s have been quite revolutionary of the fact that they actually promote weight loss and actually can actually benefit the actual underlying diabetes by having reduced weight loss, reducing your weight. So Kathleen, they're trying to shock people. And if they'd read the paper that comes in the package, these side effects have been documented in the leaflet right from the beginning. They are being highlighted again as we're getting more and more people treated. We can know the confidence intervals get lower. We can actually pinpoint the risk more precisely. As we treat more people, we'll be able to pinpoint any risk factors that a person's had previously. Things like what I would think of with gastroparesis, as I was discussing earlier, Ehlers Danlos Syndrome, the collagen disorder that I have, comes with having a stretchy bowel and constipation and a slow gut transit. So people with Ehlers Danlos Syndrome are at higher risk of having gastroparesis and can end up with just spontaneous gastroparesis due to the Ehlers Danlos Syndrome. So that sort of set of people, you would know that they would potentially, if you're going to cause a drug that has the potential side effect of gastroparesis, that increased risk may be more for them. So you've got to take that on board. But people are only wanting to lose weight and not the side effects that come with it as a shock. And this reminds me, so I've done a video about these medications, and if I can, I will leave a link to that actual program, that actual video, if you wanted to go back and see it. But people just want the they just want the to lose weight. And I had somebody tell me sort of an anecdote of their friend, and although it's an anecdote and you can't read that this is going to be everybody's experience, it is actually typical from what we know of GLP-1s. And they jump straight in it instead of listening to the advice of you start at the low dose for a week, then increase, but stepwise as you get used to the side effects. They wanted to straight away have the benefits. So they started straight away at the higher dose. And they also decided that they wanted to go out for an all-you-could-eat meal, one of these buffet styles where you can eat everything that you want. And they went out expecting the fact that they're having this weight loss injection and they can eat whatever they want. And it came as a great shock to them that they filled their plate up and they sat there and they couldn't eat anything because they just felt so nauseous. And then they did eat some of it and then ended up vomiting. And they didn't understand how the actual medication works, that the medication was to lower their appetite, reduce the transit time and reduce the amount that they could eat. And that the reason why it causes weight loss is because it lowers the amount of calories that you take in your system. It is not you can carry on eating what you like and you will lose weight. It's this medication will help you restrict the calories that you are taking in. And therefore, because you're going to have to restrict the amount of food that you're taking in, you're going to have to look and make sure that you're increasing the nutrient density of your food to get your essential vitamins and minerals, and reducing down the amount of food that doesn't. So, yeah, it was a surprise when my friend told me that. And I said, yeah, you probably need to feed back to her that she needs to realise how these medications are actually working. So, hopefully I've explained that well. Is there any more sort of questions around the Ozempic? Obviously, I do have the video that you could watch if you wanted to. And do you have any other? Yeah. Oh, yes. So the UK does sell collagen over the counter. You can actually buy it in supermarkets. It's in most of the supermarkets. Also in the UK, the majority of people that are wanting sort of supplements, Holland and Barrett is one of our big chains. And then we have usually local herbal shops and such like that sell it. So when you come to looking at collagen, you have the different types of collagen. There's the bovine collagen, which means that it comes from cows, which is, so collagen is basically the gelatin, which is sort of the ligaments and tendons of the cow. So they sort of basically boil up the leftovers once you've taken all the meat off the carcass, and you're left with the collagen in. So it's basically the gelatin. So you could just have bovine broth is another sort of healthy way that people have said that they can increase their collagen in their diet. And it probably is the fact that people nowadays are having a lot less collagen in their diet because we have a lot more processed food. So a lot of the times we are eating just the meat. We're very privileged to be able to just cut off the meat and we discard the rest of the carcass. Whereas historically, none of the animal would ever go to waste. You would then boil the carcass to make a soup and other things, and so you would get all the collagen and such like. So there's the bovine collagen. If you don't fancy having cow products, then you can have what's classed as the marine collagen, which comes from the fish, and it's the fish bone and scales that are used, so the fish skin. So that's your marine collagen peptides. And then if you are vegetarian, there is no such thing as vegetarian collagen. But what they do is find the peptides, the actual amino acids that make up collagen, and they find plant sources for those amino acids and peptides and create a supplement that has the source of those amino acids and peptides for somebody to take, in the hope that when they then take it orally, their body will then make it into collagen when they once they've absorbed it. But as I've said, even with the bovine and the fish collagen, your body's still got to break it down into the amino acid and peptides to absorb it and then make it back up again. And if your body's not very good at making the collagen back up, it won't. Also, the fact that your body will decide where it needs the peptides and the amino acids. So you may be taking it thinking, oh, I want it because I want really soft, beautiful skin. And your body will go, nah, I actually fancy making the ligaments in your knee a bit stronger, and we'll send it down there. So your body will decide where it's being used. So, so collagen is available. The you do not need to overpay for the collagen. So decide whether you want bovine, marine, or vegetarian. Most of them come in the type 1 and type 3, which are the ones that are the most prevalent in your body, so the most prevalent ones that you want, and then just hunt around to find one that's cost effective. The fat pills that so Xenical or Orlistat or Ali was the brand names of these. They are still available on the NHS. There are still nice guidance for them to be used on the NHS, but they should only be used for a limited time. They need to be taken alongside a diet that is a low-fat diet, because otherwise, yes, you get the oily waste. So it prevents you absorbing oils and fats, and so them oils and fats go into your large intestine, and you can get what you class as anal leakage of the oil, which is not pleasant. And obviously it can also cause diarrhea and upsets. So yeah, and also because you're not absorbing the fats and oils, you can end up being your fat soluble vitamins deficient, because you're not absorbing your A, D, E, and K vitamins, and so quite often you'll need to supplement with them alongside that. So you can't take it for any length of time longer than sort of 6 to 9 months before you need to go back onto a diet that actually has fat, so that you get your fat soluble vitamins. Off the table. Yes. All you can eat things, and that's it. A lot of the time, if you want to lose weight, it is all about portion control and your overall calories in the day. There's a lot of press about a lot of people saying about fasting, and fasting being really good for you, and the massive health benefits. The majority of benefits for weight loss when it comes to fasting is just restricting the amount of hours that you're eating, which restricts the amount of calories that you eat. But we already know with things like people who fast for religious reasons, such as with Ramadan, they can just modify how they're eating the calories, and they don't necessarily lose weight, because they may gorge on food and calories in the hours before the fast and in the hours after the fast. Do men and people need more collagen? Yes and no. As you get older, your body's collagen reserves will deteriorate, because your body needs to be continually replacing your skin, replacing your tendons, and as you age, your body slows down at doing that repair, especially once you go past menopause, and the estrogen that would do a lot of the helping promote keep that turnover going slows down. So replacing with collagen in your diet or as a supplement can be helpful, just to sort of maintain for as long as you can. But it's no magic cure. It's not going to reverse the signs of aging. You're just going to just be maintaining your health as good as it can be through your older age. Love that, Helen. I might use that. So yes, it's the flat pack version. IKEA collagen. Yes. Yeah. It's just the building blocks that make up collagen. So yeah, which we should be getting the building blocks all the time. So you should be getting, you probably see them advertised what they call the essential amino acids, which is just all the amino acids that your body can't create on its own. So there's so many amino acids that you need to actually get in your diet on a daily basis, because your body can't make it. Whereas there's some amino acids that are chemically similar to some of the other amino acids, and your body can actually do the changing. It can change the oxygen and hydrogen molecule on the end and turn that amino acid into the other one. The same when I'm going to talk about omega fatty acids later. So your omega 3 and 6 fatty acids are essential, as in your body can't make them, but your omega-9 fatty acids, they're non-essential because your body can actually create them themselves from the other ones, because it's all about sort of the double bonds of the carbon atoms in there. So we can add the extra methylation of the double bonds. So excellent. So yeah, it's been great to have you on this stream again. I am hoping that my health is getting a bit better, and also that now that my daughter has started back at college, I can get into a good routine and start putting out some more regular, proper videos, as well as doing these live streams. I've been doing these live streams every 3 weeks. Is that something that you like to continue? It seems to give a good gap between them for new topics to arise, for me to talk about new things. And then I'm hoping if I can actually get on schedule, having an actual video for the other 2 weeks. So my next one, the omega-3 one, is nearly written. And then I've got loads of potential ideas. It's just a matter of finding time to do that. But we did have a bit of a issue at the start of September with getting my daughter registered for college and such like, but she's really enjoying her course. She's doing health and social care. She'd quite like to be a nurse. She definitely doesn't want to be a pharmacist. She says she's not nerdy. She's more caring than nerdy. So that's the path that she wants to take. And then she's just had her 17th birthday party. So yes, I had a house full of teenagers eating pizza last night. For those that were also on DC's stream last night when I mentioned that. But no, it's been great to have you all here. I'm probably going to, it's just under an hour. I'm probably going to finish now. And oh, yeah. Thank you, Lisa. Yeah, just make sure I quite often, I keep an eye on my community tab. So whenever, even if it's on historic ones about live streams, if you want to message me with ideas for either actual videos or for future live streams, just let me know. You can also find me on Insta at Eloise Pharmacist. I'm called on there. So you can send me a DM on there, and I will have a look and see if I can incorporate it either into an actual video or into a live stream. Also, if you can make sure that you double check whether you're subscribed, because for some reason YouTube keeps unsubscribing people, and it seems to be random. So I don't think it's people that have come and seen a new video and then unsubscribed. It just looks random that YouTube does things. Yeah, mental health, yes. I'm very much all for promoting people to look after their mental health and look after other people's mental health. Make sure that you ask people twice whether they're okay, so that when they just go fine, that you actually just double check. Are you really sure? If there's anything you need, even if it's that you just want to come and sit and just have me sit and be there with you without you actually talking. You know, so sometimes you don't need to have the answers for people. You just need to sit there alongside them. But yeah, mental health meds, they are an important part alongside therapy and coping mechanisms and skills, and even psychological interventions and psychiatric interventions. Yeah, they're all part of the puzzle. Also finding out whether people have an underlying neurodivergence that's actually, it may not be that they've got anxiety. They may just have anxiety dealing with the rest of the world because of their neurodivergence and the world not being set up correctly for them. That's what's caused the anxiety and depression, is the world is set up wrong for them and society is set up wrong for them. And so they need to have the coping skills. And what we really could do with is better understanding from other people out there to make life easier for everybody. You know, having quiet spaces is a benefit to everybody, whether they're neurodivergent or not. Also, the other thing I think I might talk about is the fact that the extreme worldwide out of stock shortages with ADHD medicines and it's causing a big problem, especially when I've already heard people say, well, just try without it. And people aren't always in that space to be able to do that. Yes, it is always good with all medication. If it's something that's not required long-term or life-saving, to actually think, does the original condition, has the original condition been modified? Can I lower the dose or stop a medication? That's always a conversation that should be had, but it should be slow and steady, making sure that the underlying condition is at a stage that can be tried before stopping it. And for some conditions, the underlying condition ain't going to disappear, so you ain't going to be able to stop the medication that's keeping somebody stable. Yeah, being left-handed in the right-handed world, it's a very simplified version, but yes, it is. My daughter's left-handed, trying to find a pair of scissors for use in the kitchen. It has been really struggling, because you find left-handed scissors for cutting sort of paper that are thing, but actually finding a good pair of kitchen scissors for her was quite hard. We had to go, my mum and dad had to go through quite a few shops to actually find her a really decent pair of left-handed scissors. And that's just, you know, something simple. And there is a lot of people that are left-handed in this world, but it's set up wrong. And it should be the same with sort of other conditions. We need to be set up that everything is accessible to everybody. So yeah, thank you all for joining me. I've really enjoyed having you all on here again. It's great to see you all. Look after yourselves, and hopefully I will be putting up a new video soon. So thank you, everyone.